Hello friends, let us now learn some important points about prostaglandin analogs. So prostaglandin analogs include PGE1, PGE2, PGI2. All these are anti-ulcer drugs. These drugs will inhibit H plus K plus ATPase and thus decrease the acid production. These drugs also increase mucus and bicarbonate secretions. These will also increase mucosal blood flow. Thus, all of this causes cytoprotective effect. So, if you see the side effects of prostaglandins, these side effects include it causes diarrhea, abdominal cramps, it causes nausea, vomiting and flatulence. Contraindications of prostaglandins, if you see, the main contraindication in pregnancy because it causes uterine contraction in pregnancy. The use of prostaglandins it is specific for Anacid induced peptic ulcer. The use is specific for Anacid induced peptic ulcer. So if you see the drugs, the prostaglandin analogs drugs are mainly of two types. One, we have PGE1 analogs. The PGE1 analogs are misoprostol, whereas we have PGE2 analogs. The PGE2 analogs include N-prostil and rioprostil are the PGE2 analogs. Then we have to learn about the next important group of drugs, which are antacids. Antacids cause fast pain relieving in peptic ulcer disease. They cause fast pain relieving in peptic ulcer disease. The drugs antacids used as antacids are aluminium hydroxide and magnesium hydroxide. So these aluminium and magnesium hydroxide are contraindicated in tetracyclines as they decrease the absorption of tetracyclines. They are contraindicated with tetracyclines. You cannot use aluminium hydroxide or magnesium hydroxide with a tetracycline. Then if you see an ideal antacid is insoluble and capable of neutralizing the acid. This should not liberate carbon dioxide and this should be non-absorbable. And these ideal antacids should not disturb the acid-base balance of the body. These antacids should not disturb the acid-base balance of the body. Then we have drug interactions. Then in the drug interactions, these antacids will form insoluble complexes with iron, tetracyclines, fluoroquinolones, and they also form insoluble complexes with ketoconazole. So first, antacids are of two types. One, we have systemic antacids. Second, we have non-systemic antacids. So in the systemic antacids, we have sodium bicarbonate and sodium citrate. Sodium bicarbonate is very effective and it has rapid neutralization. But now, these sodium bicarbonate and sodium citrate are not used now because they are highly water soluble and they also release carbon dioxide. If they release carbon dioxide, they cause abdominal distension and belching as side effects. They also cause metabolic acidosis and rebound acidity. Whenever there is increased sodium load, this increases the fluid retention, especially in hypertension and congestive heart failure and renal insufficiency, which will worsen these congestive heart failure and renal insufficiency disorders. Contraindications are they are contraindicated in hypertension, congestive heart failure and in renal insufficiency. So these are systemic antacids. Then we have non-systemic antacids. In non-systemic antacids, we have two types. One, buffer type, second, non-buffer type. So in buffer type of non-systemic antacids, we have aluminium hydroxide. This aluminium hydroxide combines with the HCl in the stomach and it forms aluminium chloride. This aluminium chloride will combine with bicarbonate in the intestine and it forms aluminium carbonate, aluminium phosphate and sodium chloride. This aluminium phosphate will cause constipation, whereas this sodium chloride can compensate the loss of chloride. Sodium chloride can compensate the loss of chloride. Then the second important drug is magnesium trisilicate. This magnesium trisilicate, in the presence of the HCl or in the stomach, because of HCl, this magnesium trisilicate forms magnesium chloride and silicon oxide. Then this magnesium chloride, in the presence of bicarbonate in intestine, it forms magnesium carbonate and sodium chloride, and thus it causes diarrhea. See, aluminium hydroxide to aluminium chloride, whereas magnesium trisilicate to magnesium chloride, both these occurs in stomach in the presence of HCl. After the action of HCl in the stomach, this aluminium chloride and magnesium chloride will pass through the duodenum and reach the intestines. And in the intestines, in the presence of HCO3 minus, that is bicarbonate present in the intestines, so aluminium carbonate will form aluminium chloride will form aluminium carbonate and phosphate, whereas magnesium chloride will form magnesium carbonate and sodium chloride. So the action of these drugs is in two places. One in stomach, in the presence of HCl, it is activated first. Later in the presence of intestine, in the presence of bicarbonate, it is activated the second time. So if you see, magnesium and aluminium salts can be used together because one is causing constipation. Aluminium phosphate is causing constipation, whereas magnesium carbonate is causing diarrhea. So both magnesium and aluminium salts can be used together. Non-buffer type. First, calcium carbonate, in the presence of HCl or stomach, it forms calcium chloride, which in the presence of carbonate, that is intestine, it forms calcium carbonate and calcium stearate. This calcium carbonate causes carbon dioxide belching, and this calcium carbonate, in the presence of milk, it causes hypercalcemia, renal insufficiency, and it also causes metabolic acidosis. Thus it results in milk alkali syndrome. Second, magnesium hydroxide will cause diarrhea. Then the next important drugs are ulcer protectives. In the ulcer protectives, these ulcer protectives are actually a complex of aluminium hydroxide with a sulfated sucrose, which is called sucralfate. This sucralfate, in the acidic pH of the stomach, that is pH less than 4, this sucralfate will undergo polymerization and this will form a sticky gel. And this sticky gel can adhere to the ulcer base. It forms a sticky gel and it can adhere to the ulcer base, and it will lead to formation of barrier against the acid pepsin. Now, this sucralfate also activates the mucus, bicarbonate and prostaglandin secretion. And if you see the side effects of the sucralfate, it causes constipation is the most common side effect, nausea, and aluminium toxicity can occur, which will result in renal failure. Aluminium toxicity will cause renal failure. Now, if you see the interactions, these drugs are never given with proton pump inhibitors. These will decrease the absorption of digoxin, tetracyclines, ketoconazole and fluoroquines. These will decrease the absorption of digoxin, tetracycline, ketoconazole and chloroquines. Then we have the next important drug is bismuth compounds. Bismuth compounds can be divided into two types. One, we have colloidal bismuth subsalicylate. Second, we have bismuth subcitrate potassium. Bismuth subcitrate potassium. Now, this bismuth compounds, we do not need polymerization of bismuth compounds in acidic pH. So, these bismuth compounds can be given with proton pump inhibitors. So if we see the side effects, bismuth compounds can cause stool blackening, they can cause tongue blackening, and they can cause side effects like osteodystrophy, and they can also cause side effect like encephalopathy. So these are the side effects of bismuth compounds. Now if you see the treatment of this peptic ulcer disease, we have triple therapy, quadruple therapy and sequential therapy which is available for treatment. So first, in H. pylori therapy, in the triple therapy, we add proton pump inhibitors with 2 antimicrobials. These 2 antimicrobials are selected among clarithromycin 500 mg BD, amoxicillin 1 gram BD, metronidazole which is 500 mg BD. So this triple therapy is given for 14 days. Then we have quadruple therapy which is again given for 14 days. Here we give triple therapy with colloidal bismuth subsalicylate, and the triple therapy can be proton pump inhibitors with metronidazole 500 mg BD, or tetracycline can be given, and also we combine it with colloidal bismuth subsalicylate. So if you see this, that is quadruple therapy. Then in sequential therapy, it is given for 10 days. In day 1 to 5, we give proton pump inhibitors and amoxicillin 1 gram BD, and in day 6 to 10, we give proton pump inhibitors and clarithromycin 500 mg BD is given, and we give tinidazole or metronidazole are given in the dosage of 500 mg BD. This is one group, and in the that is one regimen. In the second regimen, we can combine proton pump inhibitors with amoxicillin and levofloxacin. These are given in 250 mg or 500 mg BD for 10 days. So this is the important treatment of H. pylori infection. Thank you for watching. That is peptic ulcers. Thank you for watching.